PCI.
Honorable Chairperson, respected panel.
Good afternoon and welcome to you all. Respected panel of experts, dear teacher and senior and junior colleagues, Assalamu alaikum. I am Dr. Sudhakar Sarkar from Green Life Medical College. An unwanted simple mistake can cost a life. This is Mrs. X, 37-year-old lady, presented with severe chest pain on and off for 8 hours, relieved by sublingual nitrate. She was diabetic, hypertensive, and dyslipidemic. Baseline investigation, troponin I and echo was normal. This was the ECG showing infralateral ischemia with borderline STF in the AVR. So our diagnosis was acute coronary syndrome in the form of unstable angina and planned for coronary angiogram. Angiogram revealed it was a radial route. Tiger 5 French catheter was taken. RCA was non-dominant, normal. On left system, there was critical stenosis in the LM. L6 was dominant, and there was around 80 to 90% stenosis in the distal L6. LAD ostium has around 60 to 70% stenosis. During angiogram, patient developed severe chest pain with gross ST depression and partially relieved by sublingual nitrate, pethidine, and fentanyl. This was the LM. It was actually hanging. So it was a case of double vessel disease with critical LM in the form of in patient with acute coronary syndrome. Patient had frequent attack of chest pain and temporary relief by nitrate. Patient party was offered for urgent bypass, but they preferred PCI and report CABG. It was Thursday, 8 p.m. weekend, and next day was Friday and closed day. IBUS facilities was not available in my hospital. This was another drawback for left main cases. So should I go for PCI without IBUS? Should I wait for next day in this kind of LM with patient with acute coronary syndrome? I was in puzzle and in trouble. Patient had frequent attack of unstable angina with gross ST depression before and after angiogram and partially relieved by nitrate, pethidine, and fentanyl. PCI was planned in the same setting considering risk-benefit ratio of the patient without waiting for IBUS management. And very high risk bond definitely was taken. I switched to femoral route. It was 6 French JL guide. Lesion was pre-dilated with 2.5 into 15 mm sapphire balloon. After pre-dilatation, result was acceptable. Unfortunately, there was twisting of wire in the left main. Balloon was not crossed to the L6, so LED wire was temporarily taken off. Then L6 was pre-dilated and 2.5 into 28 mm diagelutic stent was deployed in the L6. During stent deployment, patient developed asystole in the L6. So CPR started, CPR continued, and urgent TPM was done. LED was rewired quickly. Anesthesiologist was always with us from beginning. This was the condition. LM was 100% occluded, so all this left system was shut down and patient collapsed. Then urgent 3 into 18 mm diagelutic stent giant sulpime was deployed quickly, LM to LED, blindly. And after stenting, flow recovered immediately. Rewiring of the L6 was done to prevent or treat any unwanted pinching of the L6 ostium. Push dilatation was done with 3.5 into 10 mm NC balloon. After push dilatation and port, this was the result. LM seems to be normal, L6 ostium normal. LCX LED flow was acceptable. So final result was acceptable with good TV3 flow. After PCI to LM, BP rose to 230 by 130 millimeter mercury, and patient developed hypertensive LPF and managed in CCU accordingly. This is the X-ray before angiogram and after PCI. And on the next day at 6 a.m., patient developed polymorphic ventricular tachycardia. It recovered spontaneously, and it was started with bradycardia with prolonged QT interval. And QTC was prolonged; it was 558 milliseconds. And factors responsible for this polymorphic BT was excessive diuresis with negative balance, causes hypokalemia, hypomagnesemia, and metabolic alkalosis. All of this aggravates hypokalemia. And all supportive treatment was started, including magnesium sulfate, injection KT, calcium gluconate, and tablet amiodarone and beta blocker was started. On next day, ECG became stable, QTC became lower, 470 milliseconds. And I am always grateful to my cath lab team and my CCO team. This was the phase of my patient, and she was discharged on the next day with stable hemodynamics. Take home message: LMPCI is always challenging. If it's associated with dominant LCX with significant stenosis LCX, it becomes more challenging. Image guided LMPCI is always advisable, but in the setting of critical LM with acute coronary syndrome, life saving is more important. Post-procedural complications should be identified and should be managed accordingly. And after PCI, job is not finished yet. And again, thanks to God and thanks to my cath lab team. Thank you all.
Thank you, Dr. Sarkar.